Hello guys, I'm Deepak Shukla. Welcome to our channel Study Mania. Today let's learn about different conditions of recurrent laryngeal nerve palsy or superior laryngeal nerve palsies. This is the second video regarding laryngeal nerve palsy. In the first video we have seen about the normal anatomy and the nerve supply of larynx. Okay, so before seeing this video please see that video once. Let us see different conditions. Coming to the first one, we have unilateral recurrent laryngeal nerve palsy. Okay, so what features we'll see here? First one, what happened to the sensory loss? Okay, suppose this is the larynx. Okay, divided by like midline. Recurrent laryngeal nerve supplies the lower half of the vocal cord. Okay, sensory supply to the lower half of the vocal cord. Okay, so since let's suppose only right recurrent laryngeal nerve is inward, so what will happen? Lower side and the right side of the vocal cord, okay, is inward. So same side below the level of vocal cord, the sensation is lost. Coming to the motor loss. So we should be knowing what muscle does recurrent laryngeal nerve supply. Okay, so it supplies all the muscles except cricothyroid. Okay, so all the muscles will be paralyzed except cricothyroid. Okay, so what is the work of cricothyroid? It is not paralyzed. So what is the function of this? Tensor and adductors. So it will go to the midline. Okay, because it is not paralyzed. In left side all muscles are intact, so they'll behave normally. Okay, so in left side it will be in intermediate or neutral position, whereas in the right side, since adductors are paralyzed, so only cricothyroid is working, so that will pull it into the midline. Okay, so here in the right side the space is reduced, whereas in the left side space is still there. Okay, so there will be respiration problem only in exertion. Okay, and phonation, since again one side of the vocal cord is coming, okay, to the midline, therefore there will be mild or no change in phonation, and there is no chances of aspiration, or maybe there may be some chances. Coming to the treatment, we have to wait and watch. Okay, so for unilateral recurrent laryngeal palsy, you have to see where is the sensory loss, motor loss, phonation if there is any problem, respiration, chances of aspiration, and the treatment. Coming to the bilateral recurrent laryngeal nerve palsy. Okay, so bilateral, so below the vocal cord both side will be having sensory loss because it supplies to the part below the vocal cords, sensory supply. Coming to the motor loss, both sides only cricothyroid is working. Since only cricothyroid is working, it will go to the midline. Okay, tensor is normal and it is going to the midline, so there is no problem in phonation, because if you want phonation there should be adduction, but during respiration you will see the stridor. Okay, because they are unable to go to the lateral positions. Okay, so they are unable to do the abduction, so respiration we have stridors. There is no risk of aspiration because it's already closed. Okay, these tensors are in the midline, so there is no space, so there is no risk of aspiration, but this is an emergency condition. Okay, because there is so much of problem in respiration. Okay, so you have to go for tracheostomy. After patient stable, you have to go for type 2 thyroplasty, means you have to lateralize the vocal cord. So this is the treatment of bilateral recurrent laryngeal nerve palsy. So that was about the recurrent laryngeal nerve palsy in which there was problem in abduction. Okay, so the vocal cords were coming into the midline. Okay, so it depends upon it is unilateral or bilateral. If it was bilateral, it was more severe because it was coming to the midline. Okay, both sides. Now let's see about the superior laryngeal nerve palsy. Before starting only, you should keep in mind what does superior laryngeal nerve supply. So it supplies to the cricothyroid, and the function of cricothyroid is tensor and adductor. Okay, now let's start with the conditions. Suppose we have unilateral superior nerve palsy. Now I'll take at the right side as usual. Okay, so where will be the sensory loss? Now, since superior laryngeal nerve supplies the upper part, like above the vocal cord, sensory supplies, so therefore there will be loss in the same side but above the vocal cord, sensory loss. Okay, for motor loss, cricothyroid is paralyzed on the right side. If cricothyroid is paralyzed, there will be no tensor, like this is there, no, there will be no tensor, so it will be flaccid. Okay, and there is problem in adduction also, so it's very difficult to go this side, but all other muscles are intact. Okay, so that will pull it to the like away lateral sides. Now coming to phonation. Okay, since it is not coming to the midline, there is problem to the phonation. On the opposite side it is coming, but this side there is more space. Okay, so there will be breathy voice. What type of so there will be breathy voice in the phonation. Okay, loss of tone and loss of pitch, that is very difficult because there is so much of voice. Okay, so much of space, air filled space, because it cannot come to the midline. So this is also known as askew position. Askew position. Okay, during respiration there is no effect because there is space, so it's very easy to the respiration. Okay, for respiration. Now there is mild to moderate risk of aspiration, because there is a space, there will be more risk of aspiration. Treatment, you have to go for type 1 thyroplasty. Type 1 is medialization of vocal cord. Okay, so this was about the unilateral superior laryngeal nerve palsy. Coming to the bilateral part, bilateral superior laryngeal nerve palsy. Now you can tell me where will be the sensory loss? Above the vocal cord, both right and left side. Simple. Motor loss, since both side cricothyroid is paralyzed, so it cannot come in midline, it will be in the abducted position. Okay, highly abducted position. So there will be no problem in respiration, but the patient cannot speak at all. Okay, phonation is aphonia. Respiration is normal because so much of space is there. There is very high chance of aspiration, because since space is more chance of aspiration. This is a emergency condition. What you have to do? We have to go for tracheostomy. Okay, tracheostomy, because there is chances of more aspiration. Okay, and you can as well do tracheoesophageal diversion. Okay, and after that we can manage the voice. So what is tracheoesophageal diversion? So this was full trachea. Okay, this was full trachea. We can cut this trachea and we can do a permanent tracheostomy from here, and from here we can have a link of this trachea to the esophagus. Okay, to reduce the chances of aspiration. Okay, so this was very simple. So this completes our bilateral SLN palsy. Okay, unilateral and bilateral is done. Now coming to combined palsy. Combined palsy of one side. Okay, unilateral combined palsy. So what will the sensory loss? Upper side because of SLN, lower side because of recurrent laryngeal nerve. Motor loss, all are paralyzed. Okay, so there will be neither tensor nor adduction nor abduction, so it will be in the intermediate position or cadaveric position. Okay, phonation, again since it cannot abduct, so again there will be breathy voice because of the more space. Okay, there will be inability to increase the pitch or tone. In respiration it is not affected because it is in the intermediate position, but there will be dyspnea on exertion. There is mild to moderate risk of aspiration. Okay, and again you have to wait and watch. Speech therapy is given if needed, and treat the aspiration also. Coming to bilateral combined palsy. Okay, so whole like sensory loss is there. Upper side, lower side, because upper side because of SLN, lower side because of recurrent laryngeal, and both sides. So all muscles are paralyzed. So again it will be in the intermediate position and floppy on both sides. There will be no problem in respiration, but there will be aphonia. Okay, because to phonate it should come in the midline, but it is not possible here. There is very high risk of aspiration because bilateral superior laryngeal nerve palsy is there. So to prevent the aspiration, we have to go for tracheostomy and then diversion. Okay, so this was about the different conditions: unilateral, bilateral, and then combined palsies of the laryngeal nerve. Okay, thank you so much.